shock and figure out who is actively bleeding. I'll return to this theme a couple of times during this talk because it's really important. You have to use a lot of adjuncts to determine this. The blood pressure is probably one of the first things, and oftentimes the manual blood pressure is more important than the automated because it may not sense a blood pressure. So we've moved to getting the first blood pressure in the manual immediately on arrival to the trauma room. And in the elderly, we put a cutoff of 110 as your hypotensive level. So anyone over, elderly is relative, but I think for us, age cutoff, it's over 65 where you have other cardiovascular morbidities. And medication is when we look at 110 as our cutoff, but 90 is the usual cutoff in ACLS. We look at shock index, I've talked about that, or use heart rate over systolic blood pressure. It's a quick thing that you can evaluate, and if it's over 0.6, you have to have some suspicion that you could have shock. Base deficit greater than 5 or 6 is also important. If you take all these together, in centers that have massive transfusion protocol, you're often activating that, presuming that the patient has some type of shock as you progress where they're bleeding from. And then that brings in your adjuncts of your chest x-ray, pelvis, your back exam, having that ultrasound ready and having the facile with doing the ultrasound is very useful. You can repeat it when you have diagnostic dilemmas. And I'll often put the patient in some downward and repeat it to improve the sensitivity because it'll fill Marsden's pouch with fluid or blood when you do that.
How are you? I have a question about
CT imaging is very useful, but not for the unstable patient. You're looking for contrast examination and fracture pattern, as well as all the numerous concomitant injuries. Here's some examples of that contrast examination. Marked for you with arrow. You can see they can be adjacent to fractures. And I think most people would get your interventional radiologist involved with these examples of contrast examination. You can classify the fracture in a few ways. You'll see two different types described. We usually use the Young-Burgess method. I'll show you the tile of interest now. And the tile technology has more to do with stability. So here you have lost rotational stability, there you have both vertical and rotational stability that is lost. This is the one we usually use, the lateral compression fracture, where the fracture is coming in from the side. You can have fracture patterns like this. The type 3 is the worst, where there's contralateral displacement. And then the anterior posterior compression is the one we usually talk about in the open book, where you have an anterior injury. You can imagine someone on a motorcycle crashing into their handlebar and opening this pelvis up from front to back, severing the posterior ligament.
Yeah, he was saying.
And the type 3 of both of these are the worst. The vertical shear is also very impressive for bleeding, as you can imagine. So those were all those blood pressure. This is just some additional notation to tell you that these three are vertically stable, but rotation unstable, and they both are obstructed. So when we look at this overall and who requires embolization, this is a multi-center study where they use multiple adjuncts, and 83% of the 12 patients with APC3 type injury required requiring hemorrhage control. Transfusion, increasing age, and vertical shear pattern predicted some mortality. But this slide shows you, let me skip over this one. Here is where we have a breakdown of the morphology and what happened to them, and you can see that a majority of APC3 requires intervention, but note that over half of the vertical shear also required intervention, and to a lesser degree, the third type of lateral compression fracture. So how do you treat these complex injuries? I think before we launch into really talking about the pelvic fracture and hemorrhagic shock, I'd like to pay attention to some of the other considerations we have, including pitfalls that you may encounter. There is an incidence of rectal injury, vaginal injury, and urethral injury. So that's one of the few times where you have to do a digital rectal exam in trauma. I think most surgeons grew up learning that you put everyone in the trauma room has a visual rectal exam, and the only excuse is if the intern doesn't have fingers on both hands. But I think we recognize that there's few indications that are important, including spinal cord injury or suspected spinal cord injury, someone with head injury potentially, and then in this case where you want to rule out this rectal trauma early, because while you're doing the complex management of hemorrhagic shock and this gets undiagnosed or misdiagnosed, you will end up with severe sepsis in hospital day 3 or 4 that will then affect your mortality. The same can be said for vaginal injury. If you have a rectal injury or vaginal injury, you may have to divert the stool stream early in the of course, I think rarely we have to do a pre-sacral drainage procedure. Urethral injury is interesting if you have the classic hematoma in the scrotal region, cranial region. I would investigate with a retrograde urethrogram before placing a Foley catheter. If you have urology handy, they can come help you with this. Usually it involves placing a catheter in a very tip of the penis and then injecting contrast while you displace the penis laterally so that you can get a view of the urethra as it crosses where the pubic tubercle is, which is usually where it's disrupted. I think you can oftentimes proceed without this, especially if you're managing someone who is an extremity, and then call urology to the OR to help you. And oftentimes they'll try and just pass the catheter gently and see there's resistance, but you can have false passage and major injury with that. So please be careful. So what do you think is bleeding when the pelvis is injured? And I think that's also important when you're considering how you're treating this. And even in the sickest patients, 85% of this is venous or bony or soft tissue bleeding, and only about 15% is arterial. And I think that dictates how you're going to manage this. You want to be careful to rule out other sources of bleeding, and that's why the management of the complete trauma patient is important, looking for chest trauma or abdominal trauma as sources of bleeding, or external hemorrhage from a bad scalp laceration, or extremity bleeding that can be managed with a tourniquet should all be considered. As a reminder from APLS, what you're looking for when you're dealing with this sort of life-threatening bleeding is a blood loss of at least 30 to 40%, which is in a 75 kilo individual, is close to 1.5 to 2 liters. So you're looking for somewhere that's hiding about 2 liters of blood in order to figure out where hemorrhage is. And this is what you're working against. As the time ticks, you're going to deal with ongoing acidosis, coagulopathy, and hypothermia. And as this lethal triad progresses, you're going to get closer and closer to mortality. So we talked a bit about pelvic binders, but this is on the screen left is a commercial device. I think in the picture maybe a little bit high. On the right side you see, I think, yeah, it's a little high there. On the right side you have someone putting on a makeshift sheet. I think when I was taught to do this, you pull the sheet tight and twist in the middle. I think it's more effective, having seen some presentations that have done this, if you get the sheet on either side and pull it together, not necessarily twisting in the front, but just as tight as possible, and then using a bunch of clamps on the side, on one side to hold it in place, almost like you're wrapping the pelvis as opposed to twisting in the middle. But these are quick ways to do this. You should put your binder centered more on the trochanter, so even in this diagram, a little bit high, you want to be a little bit lower where the trochanter is on either side, so make sure you feel for that. So this is what you're doing with that. If you look at this volume of a cone formula, an increase in the radius by only 2 centimeters is equivalent to 1.3 liters. So you can effectively change that volume quickly, and that's where all the blood is hiding. And they've been shown to reduce 24-hour transfusions compared to external fixators in one trial. I think because of how quickly it can go on, how simple they are to use. But some form of definitive fixation is also useful. I think several of you may be familiar with a C-clamp that can be placed even in the trauma bay. And a lot of orthopedic surgeons are fast silent, throwing on an X-fix in the OR when you want them to. The pitfall with the binder is you can't leave it in place for several hours at a time because of pressure injury. So it's important to consider that. We're often taught that it's not effective in lateral compression or vertical shear fractures. Having discussed this with orthopedic surgeons, I think putting the binder on is better than not having it, because when you transport someone or move from one setting to another, like the ER to the ICU or the OR, you'll be redisplacing those fractures. So having the binder, even if it may not be effectively reducing volume, lends to stability of the fracture while you prepare these sick patients. So external fixation is something that's quick, can be done in the OR. This is sort of a look in the, if you were to try and explore this region, this is not recommended because of all the bleeding that you unleash. You take a contained space and then liberate it into the abdomen proper, which can hold several liters more. So the principle should not be direct control. I think this is useful sometimes in penetrating trauma, where you can isolate one branch of the iliac and sort of encircle it. But for blunt, you will end up with exsanguination if you're trying to attempt this. The next step in treatment is usually angioembolization. So you're calling your IR folks, and this is obviously preferable to open techniques. Very few centers that actually have IR providers in-house after hours, but they're usually on call 24/7 and can come in. There are some logistic concerns of continuing to monitor the patient in IR and rendering anesthesia while in IR. So you have to think about the indications. About 1/4 of patients have no bleed when they do this. I think we'll go over some other things later with indications. But one of the things is contrast examination and what the significance is. In this study, only 75 of 495 patients had contrast extrapolation. Of those who had angiogram, only 17 had embolization. So you don't have, it's not a huge number to have this, but finding is important in guiding who gets embolization. But these guidelines were first written revised in 2011. They looked at this question, and the unstable patient with ongoing bleeding after non-pelvic sources have been addressed meet criteria for angioembolization. The presence of the arterial contrast extravasation on CT scan. You have someone who you resuscitated, response, stable enough to get the CAT scan, and then they have extra. Those warrant having angioembolization. And then there's level 2 recommendations, so not necessarily randomized trial evidence, where unstable patients after angiogram may repeat angiogram. And then elderly patients, those with open book or vertical shear morphology may need empiric angiogram. So that affected practice patterns with respect to this. I think with those fracture patterns, you see on X-ray you have to have a low threshold to go to angiogram if you're stable.
What did you tell me about Barney?
A little bit more about that. And risk factors for recurrent bleeding is obviously persistent hypertension after embolization, persistent acidosis, and no other abdominal source of embolization. There's an entity known as damage control angioembolization. So you go in there and you do a surveillance angiogram in an unstable patient. You don't find something that's active. You try and limit the time in the IR suite. You gel bead embolized bilaterally. I think a lot of times patients may have vasoconstriction and there's profound shock, and you may not see extravasation. There's also collateral from both sides, so that's an argument to do this. Because of that initial vasoconstriction, it can fail in up to 50%, and then you re-embolization. And then when you talk about complications, the group in Denver, as part of their larger study looking at some of the surgical management, talked about angioembolization, and they found that this was one of the major complications. Anecdotally, this was only one patient in 7 patients who had empiric embolization in their pre-peritoneal packing study, but it was significant enough to make them take note and pause of the use of empiric embolization in a specific patient. What's shown is basically really the process and infection after this embolization of a severely injured trauma patient. The next treatment avenue you can embark on is pre-peritoneal packing. There's a couple ways to do this, but to essentially enter the space of rescue for those by either doing a low midline or a Bannon steel incision. You get into that space, and the principle is that 85% of bleeding is not arterial. So even with external fixation of some sort, with a binder or external fixator, there is a role to packing the space to control the venous bleeding. And what's described as placing pre-packs on either side, it can be rapidly done. If you bear with me, I have a video I'm going to try and share here. Let's see if this works. Can you guys hear this? This is from the acid course. Make it full screen.
Is there supposed to be sound coming from it?
VJ, we can see it, but there's no sound other than your voice.
Okay, yeah, I'll just talk over it. I think there's not much in the way of audio for this, so I'm going to continue. Especially talking about doing this in someone where angiomodulation is not available. You can stay in the retroperitoneal space. You can see there that they're getting down to the anterior rectus and not enter the peritoneum.
VJ, the only image that we have, or at least that I have, is just a cartoon of the blood vessels in the pelvis. It hasn't progressed to any sort of.
Okay, hold on a second. Let me just regroup here. Sorry about that. Okay. Let me go back to the. Okay.
That's looking good.
All right, can you see this? Okay, let's try this. So he's making an incision below the umbilicus. You're dissecting down until you reach the anterior sheath. You cut that. That's the anterior rectus fascia. And you stay above the peritoneum. Usually this is also the blood. The typical.
No, this is not the OR.
Typically you're packing.
No, this is
It's going to that
packing
posterior on
the
either side.
retroperitoneal space for a pelvic bleed.
Alright, let me go back to this. Alright, can you see my slides again?
No.
VJ, we're looking at a radiograph with a bunch of radio pigtails in the pelvis after preperitoneal pack.
Okay, hold on. Let me just get this on track here. Thank you.
Now,
Alright, so let's go back to the slides here. Okay. So you're getting into this space, back 3 on each side. And if you leave it close in the center, it's easier for radiology to then investigate on the other side. Let's do this, see if they need embolization. So, does it work? I think they've had a good reduction in mortality in their high-risk group when they looked at it from their, in Denver, when they did this initially. And they, in their group, only about 13% required additional embolization, in fact, after this was done. I'll go through a second case where I had to do this. So this is a pedestrian who was run over by a car with significant bleeding, and the usual breath sounds and airway were okay, but she was actually initially not hypotensive and did not show much going on initially, but then progressed in the trauma room to becoming hypotensive in the 70s. This is her initial x-ray on the chest. This was her pelvic fracture. So after all those initial things, she became unstable, and so we changed gears, activated the transfusion, and went to the OR. I did pre-peritoneal packing, and then went to IR. So here you can see a couple of things. This is actually external fixator that was placed, bringing the thing into production, and then I left my tails for the pre-peritoneal packing in the center, so that when IR was on, you can see my skin staples here. They sit down and or look with angiogram on both sides. So new things to try on the horizon. I think a lot of you have heard of Ebola or the retrograde endovascular balloon occlusion. This is an adjunct for those in two settings. One for the most in extremis patients who you're able to pre-arrest or arrest, and instead of opening the chest, you can place this balloon in the aorta up in zone 1 to basically occlude the aorta as if you would do an aortic crossbar. In those who are quite unstable with ongoing hemorrhage, and you think this is for pelvic, you can put it down here below the level of the it's usually placed below the umbilicus for occlusion of the aorta just above the iliac. You try not to occlude between those points because you would then take out your mesenteric arteries or kidneys. And there's been some research into this using endovascular balloon occlusion with endovascular intervention as sort of like a bridge to your IR procedure. And these things are continue to be looked at. I think when you have someone in hemorrhagic shock, anything you can do to stop the bleeding or reduce the bleeding and hemorrhage while you're getting control is useful. I think that's why this will work very well. I think it falls into the same reason why we use pre-peritoneal packing, because you can quickly go into an operating suite and do that in centers where you have to call on a team for IR that may be half an hour to 30 minutes out, usually about an hour out to the actual procedure. This is something that is important and was studied, the effective door angioembolization time on mortality, and was presented in 2017, and every hour counts. And that's why we have actually moved towards pre-peritoneal packing early if required when the IR doc is not in-house. So you can see here that when you look at hours to pelvic angioembolization, as you go up, your number of transfusion units goes up, and your mortality tends to also increase with more and more hours to embolization, which it makes sense, but this paper basically justified in some centers the use of in-house IR or actually getting some vascular certified trauma surgeons to start the process, or going to the OR to pre-peritoneal pack. This is another extreme. If they can, they have a combined CT scanner for us to be suite within the ER. So they would take them to this room and do this. And they found that it shortened a time to procedure and transfusion requirements. Not sure we're going to go there yet. So I've given you a bunch of information about the diagnosis and management treatment. Let's look at some algorithms over the next few minutes here. And some decisions you have to make initially is you do preperitoneal packing versus angio embolization. I think when you have no other options, don't have angiogram availability, I think a trip to the OR is mandatory to do that. I think you have to do some sort of external fixation in conjunction, and even a binder or sheet is important. You can do some of these IR procedures and preperitoneal packing procedures with the binder on. You don't always have to do post-procedure angioembolization, but in someone who has ongoing hemorrhage or you're not meeting your endpoint of resuscitation, that is the next step. So that's why in centers that have it, you may want to go to a hybrid suite for dealing with these injuries. And this is the paper that talks about routine post preperitoneal packing, and it was, less than 60% had therapeutic angioembolization afterwards, and in the one study from Denver, it was only 13% who needed it. And none of the people who weren't embolized had adverse outcomes. This is a very complex algorithm that you may see in the textbook. This is kind of how I deal with pelvic trauma. If they're unstable, they have shock index greater than 1, they set this over 5, or hypotensive. Think about hybrid OR for preperitoneal packing, which is excellent, depending on what's going on in conjunction with an X-fix or a binder, and then IR embolization, they're not getting better. If they're not unstable, then CT scan is considered IR for flush. And then as Reboa catches on, I think we'll have, it'll be a pit stop before you go to the OR, and then eventually maybe even render some stability so you can go to CT scan and then IR as we get more facile with that. That's the end of my talk. Got enough time now for questions, and we can discuss anything about this. Thank you for your attention.
Perfect. And Vijay, thank you so much. The timing is spot on because that gives us about 10 minutes to entertain questions from the field. What I'd like to do is to encourage people to put their questions in the chat section, and we will get to them as we can. While you're doing that, I'm going to go ahead and kick off with a question or two of my own. When I was a resident back in the Stone Age, I was told that always be ready for a complex pelvic fracture patient on your oral boards. So I always told the surgery residents that were training under me to be prepared for a pelvic fracture question. And sure enough, I got one during my oral boards, and I think most of them have too, and you probably did as well. And I think it speaks to how it's a bony phenomenon, but it's a vascular phenomenon. It can also be a urologic phenomenon, and it could be a GI phenomenon. And it can involve the expertise of a trauma surgeon, a urologist, an orthopedic surgeon, an interventional radiologist, emergency room, and a whole bunch of other folks. So it's a complex situation, and they can be hellish to manage. That being said, certainly we're all the wiser for having listened to your talk. A couple of quick questions. With preperitoneal packing, there are two camps among us trauma surgeons, and that is a midline incision versus a fan and steel incision. You showed us the midline incision approach. I was taught the fan and steel approach, but you can use either. But what about patients who have both peritoneal bleeding and preperitoneal bleeding? So let's say somebody who has a ruptured spleen and needs a splenectomy, and then you've also got that preperitoneal packing that you need to do. What are some tips to manage that?
That's a great question, Gary. I think, so the intended incision that you choose is, because it's below the umbilicus, it affords you to perform a midline laparotomy above the umbilicus. And I think it's challenging. I have to do this a couple of times, but you can get to the abdomen and take care of the splenectomy, potentially other things. The difficulty, and you can imagine this, is if you're dealing with something that's bleeding mesentery or colon and pelvis, the principle of not opening that space rectus with your midline incision is a challenge. And so you might need to be a little bit creative with exposure, putting your book walker and really retracting on the umbilical area to get traction there. But I think that the pitfall is you can have both the incisions and what's talked about in the literature that have been known to contaminate different contaminate the preperitoneal space. But I think that the crucial principle is, regardless of the fan and steel or the midline, lower midline incision, when you're doing your laparotomy from above, you don't want to violate the space rectus from above.
Correct.
So it's certainly challenging, but it is described and definitely doable. I've had to do a splenectomy in that setting, and it is doable. You can even put in an anthera or temporary abdominal closure in the abdominal side and just put an IABAN or something over the preperitoneal space in conjunction. So definitely you can work in both spaces.
Yeah, and I think one of the things that people who aren't familiar with the technique, when they're doing it for the first time, the best advice to give them is just go where the blood is, because that hematoma will dissect that plane out, and once you're into it, you'll know it, and that's where you lay your packing in. So we do have a number of people on the conference call here that are EMS providers, and we've opened this up, thanks to Jeff Way, we've opened this up for CME as well, and we have what I suspect is a question from Harry in the chat room here that says, when and why did they stop using masked trousers for unstable pelvic fractures? So I go back to my time as an EMT back before the Stone Age, and we were trained in how to apply masked trousers or a pneumatic anti-shock garment. So any thoughts on why we aren't using masked trousers anymore?
I think anecdotally, I've never had to use one, but I had actually, when I was a resident, we had them demonstrated as part of ACLS, so I am familiar with them. I think because they constrict everything below the umbilicus, I think it's maybe too much for this process, and I think it's a lot simpler to directly compress the pelvis and not necessarily cut out blood supply to the lower extremities with your mask trousers. Does that answer your question?
Yeah, and I can chime in also and say that the mask trousers were used to stabilize fractures, and number two, to increase blood flow to the core by sacrificing it, by not delivering it to the lower extremities. And the problem with mass trousers usually isn't putting them on, although they're awkward and difficult unless you got a lot of practice to put them on, but rather the problem of taking them off. When you go to take them off, you have to be ready because their blood pressure will bottom out if you're not cautious. I agree with another chat that Jeff put in that it often takes too long to put them on, and it can represent a delay in getting the patient to the hospital. Also, we have on the line Dr. Eric Reiner, who is one of our interventional radiologists, and he was kind enough to join us today, and happy to have him on board. So this is a question for both you and Dr. Reiner, if he cares to comment. You touched briefly on some of the complications of bilateral internal iliac artery embolization. Basically, the Hail Mary embolize everything in an effort to get people to stop bleeding. What are some other complications that we've run across? You always get the feared complication of impotence, but what are the real rates of those complications?
Can you guys hear me?
Yeah, I can hear you.
Oh, okay. All right. I can tell you, having almost 20 years, I'm not sure I've ever actually seen evidence as a result. Bilateral is pretty rare. I have seen, post pain, really gluteal and deep pain. I have seen some sciatic injuries, but again, we're talking single digits when we talk about the numbers. Just the body is so well compensated with collateral circulation, and one of the problems with doing more proximal occlusion is that you affect those collaterals, but even then, you do a pretty good job. We do our best to use gel foam, which is something which kind of resorbs and over time. The whole idea is to temporize the patient until they get to the next step. So I can tell you that I've probably seen on one hand permanent injuries that we couldn't deal with.
Yeah, and I think that's
Yeah, I
one of
would
the.
agree with that.
Yeah, I would just.
Yeah,
I've had family members when we've approached them about embolization, bring that up and say, wait a minute, what are some of the side effects or whatever? You're telling me you're going to block the entire blood flow or half of the blood flow to their pelvic organs. Isn't that going to cause a problem? So I think it's important for everyone online to hear that rates of significant complication with pelvic embolization are fairly low, and certainly not nearly the problem that the hemorrhage was created. Go ahead, BJ, sorry.
Yeah, I agree with you. I think it's low, and I think the picture I shared with you, the authors of that paper from Denver really took that as a major complication, which it is, but I think you're dealing with someone who's so profoundly in shock with vasoconstriction that you then add to it this sort of bilateral embolization, and then things go awry. I think it's a rare complication that I actually have not seen doing this for several years as well, but definitely worth thinking about.
All right. Any other? I do note that someone here, likely again from the EMS crowd, saying that he cringes as to the staff in the ED cuts off the mass trousers. That's an expensive proposition. That may be another reason that we stopped using them, because too many of them got sacrificed to trauma shears. Well, we're down to the last few minutes. and really want to thank Dr. Jayaraman. Thanks for being a good speaker. Thanks for being a good colleague and a good friend. And we really appreciate your time. And thanks to everyone who joined us. A great turnout. We had about 60 folks on the call, so that's a great turnout. And looking forward to more grand rounds in the near future here at Bacchus Hospital. So from
Pleasure. Thank you, Gary.
Yep, thank you all. Thank you, BJ.
Great job, BJ.
Thank you.
Bye.